Good morning, everybody. Welcome back to another episode of Pathagonia. So today I wanted to go over some benign endometrium notes. So I'm currently on my GYN rotation. So this past week I went over a lot of cervical unknown cases and endometrial unknown cases, and then next week doing more ovarian and mesenchymal stuff. So just wanted to kind of do this video as a review, and it's always good for Surge Path just to know how to pattern endometrium, and then these are great notes and you can learn a lot from them. So let's start out endometrial cycling and dating. So the first phase, and probably my favorite or the easiest to recognize, is the proliferative phase. So that's going to occur during the cycle days 4 to 14, usually not subdivided. And during proliferative phase, you're going to see these dark blue tubular glands or donut-shaped glands with abundant stroma, low columnar cells, pseudostratified nuclei, mitotic activity, and the glands get a little convoluted later on. So one thing one of the professors or doctors in my program often talks about is first you want to assess the nuclear stratification when you're looking at a endometrial biopsy, and you want to see if you see this pseudo-stratified nuclei, then that's a good indication that you're in the proliferative phase, whereas secretory, we'll get to it later, but they won't have that pseudo-stratification necessarily. Then after you assess nuclear stratification, you can look for architecture. So low power, do the glands look tubular or donut, which is more proliferative? And then you can also assess mitotic activity. So if you're seeing mites, that's a pretty good indication that you're in the proliferative phase. Next up, we have the secretory phase. So think serrations. Not necessarily to specifically date, and it's not necessary to specifically date the endometrium unless part of an infertility workup. So you don't have to be precise in how you sign these out on the endometrial biopsy necessarily for every case, saying like day 15, day 19, etc. I know personally I would have to practice a lot more to be that precise with dating, but there are patterns that can help you pick up on what day or aspect of the cycle you might be in. So for the interval phase, that's going to be cycle days 15 to 16, and that's post-ovulation, and you're going to have scattered subnuclear vacuoles. Otherwise, it resembles proliferative phase, but you're going to have these subnuclear vacuoles, which is going to be a pretty good indication that you're in the secretory phase. Also, you can see these serrations, kind of serrated looking glands, which we contrast with in the proliferative phase. We were seeing that tubular or donut shape. In early secretory, so days 17 to 19, most cells have uniform subnuclear vacuoles. So they're going to be scattered 15 to 16. You're going to have these subnuclear vacuoles, but if you see it uniformly like this, it's early secretory, so days 17 to 19. And you want to think piano keys. So you can see the resemblance here between piano keys and these subnuclear vacuoles. And you're going to have decreased pseudostratification and mitoses. Mid-secretory, it's going to be cycle days 20 to 22. You're going to have dilated glands with secretions, apical blebs, and a single layer of basally oriented cells. In late secretory, cycle days 23 to 29, we're going to have serrated sawtoothed glands with condensation of predecidua around the arterioles. All right, moving on. We're going to talk a little bit about menstrual phase. So during the menstrual phase, cycle days 1 to 4, you're going to have stromal hemorrhage, unsurprisingly, and it's going to be very red appearing, and you can often have neutrophils, fibrin thrombi, and then fragmented glands with secretory exhaustion. All right, next up, we've got in the benign endometrium category, we have atrophy. So atrophy is normal or expected in postmenopausal women without hormone replacement treatment. Obviously, postmenopausal, your hormonal axis shifts, and that's going to change your endometrial environment and what the glands would look like. So in atrophy, you're going to have this very thin one layer of flattened epithelium with no mitoses. In an atrophic process, you wouldn't expect proliferation or mitoses and cell turnover. You're going to see this simple, widely spaced glands, often running parallel to the surface in collagenized stroma. And then sometimes on biopsy, you can have these scant strips of surface epithelium shaped like paper clips with scant stroma. So these like hairpin or paperclip shaped, that is a good sign that maybe they're just sampling superficial strips, and this could be an atrophic process. So on the right here, we have a picture of cystic atrophy, another form of atrophy with more cystic involvement. And then if features are between proliferative and atrophic, you can call it weakly proliferative or inactive endometrium. All right, so some pregnancy and hormone related changes that you can see. You can have decidualization, which is what we see here on the right, this kind of pale, enlarged cytoplasm, different look to the cells. And decidualization is caused by progestin. It's seen in pregnancy, and also if the patient is on drugs like progestin-containing drugs like oral contraceptives or other hormone replacement therapy. In decidualization, you're going to see these sheets of large epithelioid cells with a pink cytoplasm, distinct cell membranes, and round or oval central nuclei. And you're going to have associated glands are widely spaced and atrophic. In early pregnancy, before decidualization, the endometrium is hypersecretory. Another fun one is the Aria-Stella reaction. So this is kind of one of those pathognomonic images that you'll often see, and it kind of just, for me now, it triggers, I think of Aria-Stella reaction, but at first it was confusing, and I didn't really know what's going on because it looks like it's kind of messy and there's a lot going on. But this is normal, seen in pregnancy and gestational trophoblastic disease. It's an incidental finding where you have this tufted proliferation with glands lined by cells with enlarged pleomorphic hyperchromatic nuclei and abundant clear to pink cytoplasm. It can mimic a malignancy, but it is benign. And then unlike clear cell carcinoma, you'll see other pregnancy changes, few mitoses, no invasion, and only focal or low Ki67. All right, next up, still benign but dysfunctional endometrium. So dysfunctional endometrium can occur due to anovulatory cycles, which is normal in the perimenopausal period, and also can be seen with polycystic ovarian syndrome, where you have no ovulation leading to no corpus luteum, which leads to no progesterone while the follicles make estrogen, which causes stimulation of proliferative endometrium, which then either outgrows estrogen or follicle, or the follicles can't make enough estrogen, which leads to breakdown. So breakdown is something good to be able to recognize. So you can have glandular and or stromal breakdown. So glandular and stromal breakdown is going to be tight aggregates of collapsed and condensed stroma. It's going to appear very dark with hyperchromatic nuclei with scant cytoplasm. And you want to think blue cannonballs or blue balls, I've heard it referred to as, and it's kind of these condensed balls of blue cellular debris. With or without an epithelial cell rim that we see here. and you may see associated metaplastic changes. For disordered proliferation, you're going to have variably or haphazardly shaped glands, such as branching, including cystically dilated glands. Glands to cells are identical to proliferative endometrium, and you're going to have abundant stroma, and the gland to stroma ratio is often 1:1. If it becomes more than 2:1, then you want to consider a hyperplastic process, which I'll go over in the endometrial tumor section when we talk a little bit about endometrial hyperplasia and abnormalities, but this video is focusing more on benign endometrium. And disordered proliferation is often coinciding with breakdown. So I guess just at first glance, low power view, you see these like cystically dilated glands, and these kind of abnormally shaped glands can make you think of a few things. So you can think of disordered proliferative pattern, or you can also think of like an endometrial polyp, especially if you're seeing a pink background or stroma, can make you think of a polyp. Just good to be aware of. All right, next up we have adenomiosis and endometriosis. So endometriosis is whenever endometrial glands and stroma are outside of their usual endometrial cavity location, which can cause dysmenorrhea and or menorrhagia, so excessive bleeding and or pain during the menstrual cycle. Adenomiosis is when you have endometrial glands and stroma in the myometrium, and that's going to be the distance from the normal junction is not standardized. So as a rough guideline, you can use a low power 4x field. So if you put your scope on the edge and you have a 4x field and you're still seeing those endometrial glands further into that myometrium, then that's probably okay to call adenomiosis. You can have associated myometrial hypertrophy with grossly thick and trabeculated cysts. And you can also have an adenomyoma, which is when you have a leiomyoma like smooth muscle nodule with associated adenomyosis. Here in the bottom right, we have an example of endometriosis. So it can be kind of tricky. Things that pop into my mind is like you can have appendiceal specimens with endometriosis, ovarian. It can kind of spread anywhere in that region. And what you're gonna want to look for to identify it is endometrial glands, which we have here, and stroma outside of the uterus, and then often you can see hemosiderin-laden macrophages. So I've heard in Malawi, I think they talk about you want to see 2 out of the 3. So you want to see endometrial glands and stroma, or endometrial glands and hemosiderin-laden macrophages to call endometriosis. And grossly, it looks like brown adhesions or powder burns. Next up, we've got endometritis. So we have chronic and acute endometritis. In chronic endometritis, it's going to be defined by the presence of plasma cells, often associated with lymphocytic infiltrate and reactive or spindled stromal changes, with elongated fibroblast-like stromal cells swirling around glands and forming pinwheels. And seeing these other features should prompt a plasma cell hunt. So if you're seeing swirling or whirling in the stroma, you can go down on higher power and look for plasma cells. Of note, some lymphocytes and follicles are normal in this instance. Chronic endometritis may be asymptomatic or present with pain, bleeding, or infertility. Some risk factors include recent pregnancy or abortion, IUD, or salpingitis. And it's kind of a controversial topic from what I've heard to use CD138 looking for plasma cells. May lead to an overdiagnosis, so try to rely on morphological identification of plasma cells. And it can be treated with antibiotics. Next up, we've got acute endometritis. So that, as the name would suggest, you're going to have acute inflammation with microabscesses intraepithelial neutrophils, and gland destruction. This is usually a clinical diagnosis, no biopsy. Often occurs postpartum or post-abortion when you have retention of some material. Of note, the menstrual endometrium has abundant acute inflammation normally, so use clinical information to not overdiagnose. Some other endometritis, we have granulomatous endometritis, which is rare in the US. Always stain to rule out infection, particularly TB. So you want to do mycobacterial and fungal stains. Giant cells may be seen with prior instrumentation and with or without granulomas. Xanthogranulomatous endometritis usually occurs in postmenopausal women with cervical stenosis. And as the name suggests, you're going to have sheets of macrophages with foamy cytoplasm, lymphocytes, plasma cells, neutrophils, cholesterol clefts, and hemosiderin. So as the name would suggest, you're going to have a granulomatous component, and anything xanthomatous makes me think of cholesterol clefts. Next up, we've got malakoplakia. Like in the GU tract, you can have sheets of histiocytes with Michaelis-Gutmann bodies, which stain with calcium stains. All right, I think this is the last couple pages. So some other changes in metaplastic metaplasia that you can see in the endometrium are as follows. You can have this oral contraceptive effect that we kind of already talked about earlier. If it's progestin only, you're going to see decidualization like during the late pregnancy with small atrophic glands. And if it's estrogen and progestin, you can have small, inactive tubular glands with abundant stroma of plump spindled cells. Squamous Morular Metaplasia. You're going to see these solid nests of bland, immature epithelium within the endometrioid glands. And it's going to be epithelioid to spindled. They may have central necrosis and can be free-floating without adjacent endometrium. The immunophenotype is actually not squamous. So with IHC, it's going to be stained with CDX2 or SATB2. Nuclear beta-catenin, negative for P63, ER, and EMA. And it's associated with concurrent or subsequent risk of lesions or cancer, such as EIN, endometrioid carcinoma, and more. So if you see squamous morular metaplasia, you definitely want to report it, and further clinical follow-up should be recommended if it's more than just focal. Next up, we've got mucinous metaplasia or change. So as the name suggests, you're going to have replacement by columnar, mucin-rich endocervical-like epithelium with GI-type mucinous metaplasia with goblet cells being rare to see. So it's usually focal and cytologically bland. You're going to have simple architecture, tubes with rare tufting, leading to benign, or it is benign, and can just classify this as mucinous metaplasia. However, if it gets increasingly complex, associated with carcinoma, endometrioid or mucinous on hysterectomy. So on the right here, you see atypical mucinous glandular proliferation. Should prompt at least additional sampling. And then if it's confluent cribiform architecture, severely pleomorphic, or evidence of invasion, that's going to be mucinous carcinoma. So one thing I definitely learned this past week from the doctor I've been working with, our GYN pathologist, is one of the pathognomonic findings of endometrial carcinoma is going to be that cribiforming. So if you're seeing cribiforming in an endometrial biopsy, you should think of some type of carcinoma. Another benign finding is papillary or syncytial change or metaplasia. The epithelium is going to have a bright pink cytoplasm and indistinct cell borders with small papillary structures without fibrovascular cores. usually only at the surface, most common with breakdown, atrophy, or infarcted polyps, and generally has bland nuclei but may be reactive in hobnail. And it can mimic serous carcinoma, but has few mites, low Ki67, around 1%, and increased but still wild type P53. Both usually have diffuse P16 often and decreased ER. So you can see where it can mimic serous carcinoma, but obviously your stains are going to help you out in distinguishing that. All right, so we got papillary proliferation of the endometrium. So this is, as the name would suggest, a papillary proliferation, mostly seen in polyps. You can have simple or complex papillary branching, bland nuclei with no abnormal mitotic activity, mucinous or eosinophilic metaplasia, and then when you do see this, you can have risk of concurrent or subsequent CAH or EIN or endometrioid carcinoma. So anytime you see that, you're going to want to recommend further clinical evaluation. And that makes sense, right? So if you see this on an endometrial biopsy, it should prompt in your head, like, this does not look normal. You know, this isn't something that I regularly see on the endometrial biopsies I've seen so far. I'm only in my second year, but if you see something like that, it would make sense you would want to recommend further clinical evaluation. All right. Next up, we've got Tubal Metaplasia, or ciliated cell change. So you're going to see ciliated cells dominate the epithelium, and it's going to resemble fallopian tube lining. So you'll have some ciliated cells are normal on the surface and proliferative glands. It's going to be cytologically bland, with some cells having perinuclear halos. So if you see these perinuclear halos and this cilia, that's going to be good for tubal metaplasia. Other changes you may see, so on the right here we have hobnail cell change. So most common as part of post-curettage atypia or ischemic polyp as reactive atypia. You can have clear cell change with abundant clear cytoplasm or glycogen, cytologically bland, often focal or rare. And you can have eosinophilic cell change with abundant pink cytoplasm and round and bland nuclei. That's it. I hope you enjoyed the video. I know I haven't posted one in a while, but it's good to make it and be back. I'd like to make some more GYN videos in the coming weeks on GYN for another month. And then I go on to my first derm rotation. So just gonna keep the studying going, and good luck to everyone on the rise if they haven't already taken it or if they're taking it soon, and happy studies.